What's up, Ninja Nerds? In this video today, we're going to be talking about respiratory acidosis. Before we get started in this video, if you guys want to follow along with some comprehensive notes and illustrations, we'll have a link down in the description box below. Go check that out. Also, if you guys benefit from this video, you like it, it helps a lot, please continue to support us by subscribing, hitting that like button, and commenting down in the comment section. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, when we talk about respiratory acidosis, the first thing that I want us to kind of really look at is an ABG. We talked about this in our introduction video on how to interpret and how to read ABGs. This is going to just be a nice little quick recap. But let's say that you have a patient, they're in the ED, they're in the ICU, they're wherever, and you get an ABG on them, an arterial blood gas, comes back, and you get something like this that's being read on the computer. And it says, hey, this patient's got a pH of 7.29. Whew. That's a low pH, right? That's acidic. So there's acidemia present, meaning that there's probably an underlying acidosis. So let's go ahead and just put a down arrow there, indicating that the pH in this scenario is low. Now, the next thing I like to remember is if the bicarb is going in the same direction, then it's metabolic. If the CO2 is going in the opposite direction, it's a respiratory problem. We already know that this is going to be a respiratory problem because it's a respiratory acidosis video. So what do you think the CO2 will be doing? It's going up, and it is in this ABG. So we see that the CO2 is up because it's greater than 45 millimeters of mercury. Normal is 35 to 45. Normal pH is 7.35 to 7.45. Bicarb, we can see if there's compensation if we really want to in this scenario. Usually if there's an underlying acidosis, which there is, you should expect the bicarb to go up to make the environment more alkalotic. Normal bicarb is 22 to 26. It's within the normal range, so there's no true compensation here. But then I have one more thing on my ABG that's really gonna make me kind of like a little nervous. I might crap my Huggies a little bit if I see this. I see a PO2 of 50 millimeters of mercury. That's hypoxia. So you kind of determine hypoxia based upon the percent saturation, right? When we look at this, generally we like it to be 80 to 100 millimeters of mercury. If it's like 60 to 80, it's mild hypoxia. If it's 40 to 60, it's moderate hypoxia. And if it's less than 40, it's pretty bad hypoxia, severe. So in this case, I'm getting close to the severe part. I gotta be really kind of a little nervous and go figure out what's going on. So I also wanna realize that this person has a pretty decent hypoxia present, okay? Now, I get this ABG, I start thinking about, okay, what is the reason that this person has a respiratory acidosis? This is where I gotta start digging in, figuring out a lot of stuff. Go see the patient, look at their history, look at the medications, and really kind of come up with a good assessment and plan. But before we really do that, I really truly believe it's super necessary for you to have the basic understanding of the physiology in this before we start talking about the pathophys. So really quickly, in the brainstem, the most basic concept here, you have a respiratory center, right? We call it the medullary respiratory centers. In the medulla, this lower part of the brainstem, you have midbrain, pons, medulla. Here in the medulla, you have two centers, what's called the ventral respiratory group and the dorsal respiratory group. If this doesn't seem familiar, go into our respiratory physiology playlist and watch this video in more detail. But all I want you to know is that these are primarily the respiratory centers that play a lot within our rate, our depth of breathing as well, okay? When these neurons fire, okay, particularly like your VRG, it'll send signals from this actual medullary respiratory center down to these lower motor neurons in your spinal cord, okay? And what it'll do is it'll stimulate these lower motor neurons and say, hey, lower motor neurons, I need you guys to go and fire and send action potentials to the muscle. So then these neurons will fire. Well, what will happen? If we follow these nerves will then go and stimulate the muscles that are involved in breathing. One of them, big one that you really need to know here, is your diaphragm. And then the other one are these little guys between the ribs. What are these called? These are called your intercostals. And there's two types. The ones that we really need to know primarily for helping to take breath in is your external intercostals. But these are the two muscles. They're gonna contract and they're gonna play a big, big role in our depth of breathing and also the rate of breathing. When these muscles contract, they help you to take air in, right, bringing oxygen in and blow CO2 out. In a respiratory acidosis problem, what is really the issue? It's that CO2 in the blood is increasing. And why is that a problem? Go back to your equation here. If we say that CO2 plus water yields carbonic acid, which breaks down into protons and into bicarb. What did we say Le Chatelier's principle supports? If you increase the concentration of a particular molecule on one side of the reaction, it's going to shift to the opposite side to maintain equilibrium. So if I have a lot of CO2 built up for some underlying reason, which we'll talk about, it's going to cause this reaction to shift to the right and make more of what type of ion that's really causing the problem here? The protons. And these protons are going to increase in amount. And when they increase, what is that going to do to the pH? It's going to lower our pH. Okay? So that is the reason why we're having a problem here, is that we're not clearing CO2 out of the lungs. Right? So we're not getting rid of CO2 properly. There's less CO2 that's being exhaled. But another problem that our patient is having here is that they're having less oxygen coming into the lungs, or getting into the blood. And we'll have to figure out why as we go through our kind of differential here. So that's our basic physiology. To quickly recap, medullary respiratory center is fire, cause the nerves that go to the diaphragm, phrenic nerve, and external intercostal nerves to contract. When those muscles contract, they bring air in. As long as the lungs are healthy, they should collapse and recoil, and then allow for you to take and push air out. And a problem with respiratory acidosis, they can't clear the CO2 for some underlying reason we will go over. And also our patient in this situation is having a hard time getting oxygen either into the lungs or putting it into the blood for some reason, and we'll figure out why in a second. But that's our basic physiology and pathophysiology here. Now let's try to understand why this person is having retention of CO2 and less oxygen coming into the blood. First thing I like to look at is, let's go in an order. The center, the respiratory center in the medulla, why is it not firing? Is there something wrong? Is there damage to that actual respiratory center? It's a very simple concept. If I damage this respiratory center, let's kind of title that. So there's some type of damage, or we can just say there's a lesion of some kind involving this respiratory center within the medulla. What could be causes? Don't make it complicated. What if I have a big old like golf ball sized lesion in there, a big tumor there that's causing some type of aggressive destruction there? What if there is some type of underlying infection? And so we kind of think about encephalitis. So if there's some type of encephalitis, whether that be bacterial, whether that be viral, we can figure out a little bit later. And the other thing is, what if there's trauma? What if they had a traumatic brain injury and there was injury to that actual area there? That's something that we have to be thinking about. And you know what's really relatively easy to do to figure out what the right reason for this is? What could I do? I could just get an image of their head, right? So I could go and I could get a CT, or I could get an MRI. So if I went and I got a CT, maybe even an MRI, that might show me if there is a big old tumor goombach there. If I had history that they were in a motor vehicle accident, and I could also go and do a little bit more imaging as well, I could do a CT or MRI. But if I know, hey, this person was in a history that had a motor vehicle accident history, and that's the reason they're in, maybe that also could be a reason why. And then if there's an infection, again, I could get an image, but what else is another thing I could do? I could do an LP, right? I could do what's called a lumbar puncture and look to see if there is any infection there that's positive for a lot of proteins, bacteria, or viruses. Okay? So that's the first thing you want to think about. If there's damage to this medullary respiratory center, a lesion of it, it's not going to fire. It's not going to cause the nerves to fire. It's not going to cause the muscles to contract. And if you can't contract the muscle, you can't get rid of CO2 and you can't bring in oxygen. Boom. What if there's drugs? That's the next thing. I like to look about this first. This is a quick, easy one that I can look at. Is there some type of drugs that are suppressing and saying, hey, medulla, don't fire? There's a lot of them. And we're just going to categorize them. There's many different types that I could mention here for you. One of them that is a pretty bad one here is going to be opioids, right? There's many different types of opioids. Fentanyl, there's hydromorphone, there's morphine, there's oxycodone. So a lot of these different types of drugs, that what can they do? Well, they can just come and suppress or inhibit or decrease the activity of these medullary respiratory centers. So that's one. One could be opioids. The second thing that I would like to know is, Are they taking any benzodiazepines? Benzodiazepines also are pretty good at suppressing that respiratory center. So I want to know, are they taking any lorazepam, alprazolam? Are they taking any midazolam? And is that why they're taking too much of it and that's suppressing it? The other one I want to know is, are they taking any barbiturates? Okay. So maybe there's things like pentobarbital, things like phenobarbital. Sometimes these can be used for if they're in status epilepticus and you need to control it better. Or maybe they're in alcohol withdrawal and they're taking a little bit of the phenobarbital to control their risk of developing delirium tremens and something like that. So these are things I like to look at. Now, I could just look and see, did I give them any of these medications? Do they have a history of these medications? But sometimes you have to just check. And so what can I do? I can just do a tox screen, right? Or I could check a level maybe on any of these kinds of drugs here. So I could go ahead and I could just kind of figure out, do a tox screen, maybe just a urine drug screen. So a urine drug screen, figure out if maybe they have any opioids in their system, any benzos in their system, or if they are maybe some type of barbiturate, I could check a level, a serum level of that drug, okay? And that could be maybe me finding out, oh, this is the reason why the respiratory center is suppressed. There's less firing, less muscle contraction. That's why they're not clearing their CO2. The next thing I like to think about is there's something that's decreasing the metabolic activity of those neurons, that they're just not wanting to fire because they're not metabolically as active as they should be. What could be reasons for that? Good old thyroid. You can always blame everything on the thyroid, right? So if someone has maybe a decreased production of T3 and T4, that's going to lower their basal metabolic rate. And if you lower their basal metabolic rate, that might decrease the firing of those neurons. And so there's a potential that there's less action potentials that are generated from maybe the medullary respiratory center. Less firing of these nerves, less contraction of the muscles, less clearance of the CO2, less bringing in of oxygen potentially. Okay? So again, be thinking about what kind of condition here? Hypothyroidism. But another thing that you could also be considering here is something similar to this is hypothermia. Sometimes hypothermia can also do this as well. Okay, so we've kind of figured out our central things that may be causing this, right? And that could be drugs, that could be less basally metabolically active, or some damage or lesion of the area. And to really quickly recap this, hypothermia, what could you do? Check a temp, right? So check a core temp. I like to check a core temp, whether that be a rectal temp or an esophageal temp, a bladder temperature. Check a core temp. And then hypothyroidism, what could you do? You check a TSH, right? And someone who has hypothyroidism, primarily an issue with the thyroid gland itself, they would have a high TSH, right? So they would have a high TSH. And we would also expect them to have a low T3 and a low T4, as we already described here. Okay, if it's primarily an issue with the thyroid gland. Okay, we figured that out. Now let's go to the nerves, from this part here to this part here. What's wrong with this? Could there be something going on there? Okay, so how do I figure that out? So I like to look at an order, a sequential order here. Let's just go from the spinal cord all the way to the neuromuscular junction. Is there a lesion primarily of this anterior gray horn neurons? So what could be some potential reasons for this? So some type of anterior horn lesions, right? And there could be many different causes for this. One of the big ones that you obviously want to be thinking about is acute, is going to be amyotrophic lateral sclerosis, also known as ALS. And so with ALS, there is no like labs or something specific that can diagnose it. It's more of a clinical diagnosis. And with ALS, there's usually signs of upper motor neuron and lower motor neuron lesions present. It's actually combined. So that's one thing to be looking at. The next thing is, do they have an underlying poliomyelitis? So did they, not get their polio vaccine? That could be a potential reason as well. So maybe a history of not taking, history of no vaccine. And then the next thing is, do they have any transverse myelitis? So sometimes transverse myelitis could also be a reason, like West Nile fever, I think, is another one as well that could be viral as well. So you can also check for this one, maybe doing a lumbar puncture, or seeing if they have any history of fevers or muscle aches and joint pains, as well as accompanying problems with weakness as well. So transverse myelitis could be something that you could further investigate as well. But again, these are really, really low in your differential. You're usually not thinking about these in an acute respiratory acidosis. But again, something to be thinking about. So we've ruled out those. The next one I like to think about that I really want to know quickly is something like this. Is there anything that's causing damage to these myelin sheaths? Because if I have some type of demyelination, let's say that there is some type of damage to these myelin sheaths, there's demyelination. So I like to say demyelination of the peripheral nervous system axons, particularly the nerves like intercostal and phrenic nerves. And the big one that I really want to know about is Guillain-Barré syndrome. Okay, this is a nasty one, okay? This one is usually an autoimmune disease. There's usually some underlying history in your vignettes or in this clinical scenario of them having a previous GI infection by Campylobacter jejuni, or maybe having an upper respiratory tract infection where they had developed an immune response but abnormally against their own tissues and not just the pathogen. So there's usually some type of underlying history of a GI infection. Usually that's the most common type of scenario, the Campylobacter jejuni. And then also the classic sign is a symmetric ascending paralysis. So they usually start at the lower extremities and start working their way up eventually before they even get to the muscles or nerves that are actually responsible for stimulating the diaphragm and the intercostals. So something to think about there. And other things that you could do if you really want to go the extra miles, they do LPs, lumbar punctures, and they look for what's called albuminocytological dissociation. Okay? And that's just basically they have a lot of protein that's present within the cerebrospinal fluid and not a lot of white cells, okay? So a bunch of different things that you could do for this one as well, okay? So we've kind of gone through GBS. We can figure out if this is the underlying cause. The next one here is there something going on at the neuromuscular junction? What is maybe going on there? So at the neuromuscular junction, you have acetylcholine that gets released, right? So acetylcholine should get released here, and it should act on the muscle. We'll just say it'll stimulate on the muscle. There's receptors there called nicotinic receptors that acetylcholine will bind to, load the muscle with ions like sodium, and cause the muscle to contract, clearing the CO2, hopefully, if everything's normal. But in someone who has an underlying problem here where there's something going on called myasthenia gravis, it's an autoimmune disease. Just like GBS, or Guillain-Barré syndrome, there was antibodies that are being generated against these myelin sheaths. And myasthenia gravis, there's antibodies that are targeting the same receptor that acetylcholine is trying to bind onto. And so what it's doing is it's inhibiting acetylcholine from binding onto those receptors, causing the muscle to be able to get loaded with cations, and it's not going to contract as well. And so myasthenia gravis is usually also an autoimmune disease. Now with this one, usually there's some type of there's always thrown into your classic vignettes that sometimes this can be related to an underlying what's called a thymoma. And so this is usually a thymus gland tumor that sometimes could be related to this. And that's something that you have to evaluate as well. So sometimes you can think about a history of thymoma, but there's usually autoantibodies that are generated against the nicotinic receptors. So how do I diagnose it? How do I figure out if this is the issue? There's a couple things. Clinically, they usually present with bulbar weakness first. So in other words, they present with what's called bulbar weakness that then progresses to respiratory failure. So what do I mean by that? They develop double vision, their eyelids start kind of drooping, they have facial weakness, they have a hard time being able to kind of keep their head up, and this is usually worse. This is the classical finding. It's worse throughout the day. Their strength may be best in the beginning of the day, but it gets fatigued and weak throughout the day as you use it more and more and more. So it's usually bulbar weakness that's worse with activity, okay? But then again, it progresses to these muscles, it works its way down, whereas GBS works its way up usually. The easy way to identify this is clinically, but also you can check and do a lab where you check for those ACH receptor antibodies. Okay, and these are called your nicotinic receptor antibodies. Usually these will be positive. There's another one, we're not going to go too crazy about this, but it's called the MuSK antibodies as well. But again, you can look for those. You can also do an ice pack test. There's a bunch of different ways, but it's just getting the idea of figuring out a differential as you're working your way through this. So we figured out the nerve problems, right? We've gone anterior horn lesions, ALS, polio, transverse myelitis, probably on the lower end of the reasons why, Guillain-Barré syndrome, demyelinating, and then a neuromuscular junction problem, myasthenia gravis. If we've gone through all of these things and we still haven't figured it out, the next thing I like to go to is the muscles. Is there something wrong with the muscles? And often, more often than not, this is usually the cause of someone being in respiratory acidosis, is the muscles. So what do I mean by this? So the first thing is, let's think, is there some type of muscle problem? So the first one that I like to think about is, are they exhausted? This is honestly probably one of the more common reasons why someone can have a respiratory acidosis. They're just so exhausted. They have some underlying respiratory problem and they've just been breathing and breathing and breathing constantly at fast rates that their muscles have just become so fatigued that they can't keep up with the demand. And so this is usually due to increased work of breathing over time that's eventually led to exhaustion, and that just the muscles can't contract as well and they can't clear CO2. This is very, very common. The other ones, which are highly less likely, but again, if you want to be a ninja nerd and be thorough, is polymyositis and another one called dermatomyositis. Okay, and again, these are going to be much less likely, but again, if you want to be thorough, you can also think about these conditions as well. So again, muscle problem, is there something wrong with the muscles themselves where there's a decreased activity of the muscles? The first one I like to think about is the muscles are just, they're exhausted because they've been working so hard to breathe for some underlying reason. We'll talk about one of the most common causes for those. Or is there polymyositis or dermatomyositis? There's damage and loss of function of the muscles. And this requires more like a muscle biopsy, as well as other different things that we're not going to focus on. All right, so we've gotten to the point where we've ruled out that there's no respiratory center, nerve, muscle issue. Now we got to start thinking about, is there something going on with the lungs? That's the problem. And we can't get CO2 out for some reason. Okay, well, let's think about this. What if there's just something that's obstructing the airway and blocking things from being able to get out? And that's the problem. That could be a very obvious reason, right? So let's think about that. Let's say that you have some type of obstruction right here in the airway. Maybe there's just a lot of mucus plugging here, or maybe there's just a lot of collapsing of the airway because you've lost a lot of the elasticity, or there's an upper airway obstruction, maybe again mucus, or maybe there's just a big foreign body that a little kid has accidentally swallowed, and instead of it going down the esophagus, it ends up going down the airway, unfortunately. So we got to think about this. Is there an obstructive problem here? And that's why this is the issue. So I like to think about that. Is there an obstruction? So let's write that down over here. So obstruction. And that obstruction of the airway, I want to know, is it lower airway problem? So in other words, if it's a lower respiratory tract issue, this I'm thinking about COPD, right? So chronic bronchitis, I'm thinking about emphysema. So are they smokers? That's one big reason. And the other thing is, if you really wanted to examine a little bit more, you could check their PFTs. And again, they would have abnormal pulmonary function tests that we've covered in separate videos on COPD. So things that you could do for this is check their PFTs and do they have a history of smoking. Okay, and also you could get a chest x-ray, and if you see the chest x-ray and you can see like 1 billion ribs and it's super hyperinflated, and they have also maybe some barrel chest type of appearance, they have that nice cough with productive mucus. Again, these are all things that could cue you into them having COPD, and they're just plugging up them airways and not able to get that CO2 out, and that's the reason for their acidosis. So that's one big thing. And then the next thing is there an upper respiratory tract obstruction? So this is where I like to think, okay, if it's upper respiratory tract, I think about, is this a foreign body aspiration? So sometimes if it's a little kid and it's a common tendency for them to accidentally aspirate a foreign body and it gets stuck somewhere within the upper airway or maybe even in the lower airway, I got to think about that. And sometimes that may be doing a laryngoscopy, or sometimes if necessary, they might have to do a bronchoscopy. So again, that may require us a little bit more further evaluation, but foreign body aspiration. And the other one is laryngeal edema. Okay, is there any laryngeal edema? Maybe they just had the tube, they were intubated and they had the tube taken out of their airway, and there's a lot of inflammation around the area. Or they got TPA, and sometimes people can develop what's called angioedema, or there's generalized angioedema from a medication effect in general, and that's the response, there's the reason for the laryngeal edema. So again, things that may be causing obstruction: is there a foreign body, or is the laryngeal edema from a medication effect, or because they were intubated and you had to take the tube out and it's just really irritated? Or is there a lower respiratory tract problem, like a chronic obstructive pulmonary disease like COPD? Those are big things to think about. Now, the last thing that I really want us to cover is related to this exhaustion. And this has to come back and go through something of why maybe this patient is exhausted and they're having to breathe so much. Okay? Let me explain what I mean. There is conditions in which maybe there is a lot of fluid in the airway, right? Let's say that here I kind of open up an alveoli here. Here I'm going to open up an alveoli. And for some reason the person has a lot of fluid or consolidation, a lot of mucus, a lot of fluid, maybe even some pus that's in that area of the airway, and I just can't get the oxygen across this airway into the blood. So the problem I'm having here is that there is less oxygen being delivered into the blood. And what could be reasons why you would have a lot of fluid or pus in that area? Pneumonia, ARDS, right? So things I like to think about right off the bat is, do they have ARDS? Do they have pneumonia? The next thing is there a lot of fluid between the actual lungs, the lung space, and the capillaries? So is there a lot of fluid present in there? What's that called? When you have a lot of fluid between the actual alveoli and the pulmonary capillary interface. What is that? Pulmonary edema. So if they're having pulmonary edema, that's a farther distance for the oxygen to have to travel. And that may also lead to less oxygen getting into the bloodstream. And so this I'd want us to be thinking about: pulmonary edema. And the last one, which is really scary, is they throw a clot and they develop an embolus that's actually sitting here in this blood vessel. And let's say that blood is moving this way, and our goal is to get to these alveoli. Let's say it's to get to this alveoli right here, because that's where the oxygen is, and we want to get that oxygen into the blood. If I have blood flow that's not able to get past that area, and so therefore oxygen can't get into this actual bloodstream, that's going to cause a low oxygen concentration as well. Okay? And what's that called? That's called a pulmonary embolus. Okay, so this is, let me actually stick with the same color here. This is a pulmonary embolus, that little clot there. Okay, that also can lead to less oxygen getting in the blood. So pulmonary embolism. Regardless, the overall effect of these things are the same. That the pulmonary embolism, the pulmonary edema, the ARDS and pneumonia all lead to less oxygen getting into the bloodstream. That less oxygen getting into the bloodstream leads to what? Hypoxia. That hypoxia does what? Over time, you're going to want to try to do what? If you have less oxygen, you're going to want to try to breathe faster. So what that does is it activates what's called chemoreceptors, right? There's different types of chemoreceptors, central and peripheral. Chemoreceptors will be activated peripherally and cause a reflex to go to your medulla and say, hey, medulla, I don't have a lot of oxygen, you better fire faster and bring more oxygen in. And so what it'll do is it'll increase the respiratory rate and increase the respiratory depth. And you're going to breathe faster and deeper to try to bring more oxygen into the alveoli and cross it into the blood. But guess what happens? If you keep doing that over a long period of time, the muscles are going to get weak. they're not going to be able to keep up. They're going to start getting tired, and they're like, dude, I can't do this anymore. And what happens? That increased work of breathing leads to exhaustion, and that exhaustion leads to a low respiratory rate, a low respiratory depth, and guess what happens to that CO2? It starts getting retained, and then it starts causing a lowering pH. So, acutely, if someone has a pulmonary embolism, a pulmonary edema, they have pulmonary edema, ARDS, pneumonia, they may develop a respiratory alkalosis. But if they're not being treated and they're continuously working and working and working, and they're not getting intervention, eventually those muscles will give way, tucker out, and they'll start developing exhaustion and start retaining CO2 and develop a respiratory acidosis. Okay? So we have gone through all the potential causes and reasons for someone developing respiratory acidosis, which is a ton, right? And we should have an idea of how to figure these things out. And again, we're not going to try to go crazy into detail into every single diagnostic test that we can go into, but it's just developing a strong understanding, a differential of what could be the reasons why this person has an acidosis. Okay? So once we've gone through, we figured out all of these issues, let's come up with a treatment plan for these patients and what we're going to do for them. All right, engineers, so now we're going to go through treatment, and this should really be simple because we already know the causes, and guess what respiratory acidosis is? It's just treating the underlying cause. You fix the issue, it should fix the underlying problem of why they're developing this change on their ABG. So let's go through it. Let's not make it too crazy. Let's start off with what we said. There's some type of damage, there's lesion to the brain, okay? There's a lesion causing damage there. And some of these we may not be able to do anything. For example, if there is a tumor, what would you have to do? Well, maybe you have to resect it. And the other thing is you start them on steroids. Steroids help to reduce a lot of the vasogenic edema, and a lot of that edema could also be causing some problems with the respiratory centers. So you resect it, some type of surgery, and maybe even steroids to reduce that vasogenic edema. If there is an infection, right, so there is an underlying encephalitis, you can treat that with antibiotics if it is a bacterial infection, or guess what? Antivirals if it's a viral infection. And sometimes you even add on steroids again to reduce some of the vasogenic edema. For trauma, again, it's just trying to manage the actual condition and preventing any further complications. There's not too much that you're going to be doing for trauma in this situation. The next thing is, again, we talked about those drugs. These are big ones. These are quick ones that you want to be able to realize. What if they're on an opioid, okay? And they took too much of that opioid? Well, if there's an opioid overdose, you give naloxone. What if there is a benzo overdose? This is flumazenil. What if they took too much of a barbiturate? This is sodium bicarb. Okay? So those are quick little things to be able to reverse the underlying CNS suppressant or depressant in this situation. Okay? The next thing is, what if they have hypothyroidism? That's why they're having a decreased metabolic activity and decreased action potentials. Give them thyroid hormone, right? So if they have hypothyroidism, a lot of these, I swear, they're relatively common sense. You just give them thyroid hormone. And so in this case, we give them levothyroxine if we really want to be specific. So if they have hypothyroidism, you can give them levothyroxine. Okay? If they're hypothermic, you warm them up. Okay? You warm the patient. Okay? The next thing, as we said, okay, what if there is some type of anterior horn lesion? Some of those, there's not really much that you can do if they have ALS. If they have polio, there's not really much that you can do in this kind of situations. Transverse myelitis, there's even, again, not too much that you're going to be doing for those. So again, they're also relatively uncommon, not something that you're probably going to be thinking about in an acute respiratory acidosis situation. The next thing is I want to think about, okay, what about GBS? There's a demyelination of those neurons. In Guillain-Barré syndrome, there is something you can do. And with this one, what we like to do is, again, protect their airway. A lot of these patients, sometimes we'll talk about empirically what we do for these patients in a second, but if you treat the underlying disorder, you might be able to prevent this in some situations. So with Guillain-Barré syndrome, what we do is you can give something called IVIG, or you can do something called plasmapheresis, or what we call PLEX. Okay, and basically it's an exchange process where you get rid of all those nasty antibodies. Okay, and myasthenia gravis, right? Myasthenia gravis, it's the same kind of thing. You can do IVIG, or you can do what's called PLEX, that plasmapheresis, and sometimes we even do steroids, high-dose steroids. Okay, so that would take care of that issue. The muscle issue, polymyositis, dermatomyositis, again, unlikely. You could try to control some of those in other ways, but again, we're not going to be focusing too much on dermatomyositis or polymyositis. What about exhaustion? Okay, so if someone does have exhaustion or they have increased work of breathing, so increased work of breathing, what you'll probably do is you can try your best to not have to intubate the patient and put them on a mechanical ventilator. And so you can try things like non-invasive positive pressure ventilation, so things like BiPAP, things like high flow nasal cannulas. And if that doesn't work, then sometimes you may have to mechanically ventilate them. And that is usually invasive, okay? And that's where you put an endotracheal tube usually down the airway, okay? Because at this point, they're gonna eventually, their muscles are gonna give way, they're not gonna be able to breathe on their own, and so you need to ventilate for them in that situation. Okay, so what if it's not a muscle issue, and what if it's an obstruction issue? So in patients with underlying COPD, chronic bronchitis, emphysema, again, you wanna just be very careful with these patients. You don't wanna try to increase their oxygen saturations too much because they prefer to live in a lower oxygen saturation point anyway. But what we try to do with this is just control if they have an exacerbation. So you try this with inhaled corticosteroids. You even do something called duonebulation, right? So duonebs, so where you give them what's called ipratropium bromide and albuterol. And then the other thing is sometimes you may even have to do oral or IV steroids in an acute exacerbation. And again, controlling their underlying problem, these patients can also respond well sometimes to a non-invasive positive pressure ventilation, things like BiPAP or high flow nasal cannula, without having to intubate them unless you absolutely need to. For upper airway obstructions, things like laryngeal edema, that's pretty much kind of giving things like steroids. So if someone has an underlying laryngeal edema, you want to figure out what the reason for it is, but usually those people respond well to steroids and something like Benadryl, okay? So an antihistamine. All right. So that's it for laryngeal edema. Now, foreign body aspiration is pretty obvious what you do. You'd remove the foreign body in that situation, okay? So we've kind of gone through that. The next thing that you want to be thinking about is if it's these other issues that were leading to the exhaustion, right? Can we, if they are exhausted, yes, you need to try to support their respiratory system some way, somehow. But if you can fix the underlying issue in the meantime, that also may be helpful. So if you go back here and you figure out that they had pneumonia, yes, while you're trying to give them positive pressure ventilation, whether it be BiPAP, high flow, or ventilate them, treat the pneumonia. How do you treat pneumonia? You give them antibiotics, right? If it's usually bacterial, which most likely that's going to be what it is in this situation, okay? ARDS, again, it's primarily a lung issue. There really isn't any specific type of treatment other than supporting their respiratory system by giving them positive pressure ventilation, whether it be non-invasive or invasive. For pulmonary edema, when someone has a lot of edema, you want to figure out why they have that pulmonary edema. And most often, more than not, it's a cardiogenic problem. They have heart failure, left-sided heart failure, that's causing a lot of that fluid to back up. And so sometimes what you can do is you can give them diuretics, things like furosemide, to pull some of that fluid off. And that may also get a little bit more oxygenation across that area. So sometimes what we can do is what's called diuretics. Okay? And then this last one here is pulmonary embolism. This one is a very scary one, especially if it's in a very proximal point of the pulmonary circulation. With these ones, there's many different options depending upon what type you have. You can either give them a heparin drip, right? So something like heparin, a drip, and then a bolus and a drip, or sometimes they can even just do a subcutaneous one, depending if it's not super bad. Or you can do something like TPA, tissue plasminogen activator. Sometimes if they're very, very proximal, you can do TPA. And the last one is sometimes you can do what's called a embolectomy, where you surgically kind of go in, IR, particularly interventional radiology mechanism, where they go in and pull that clot out as well. mechanically, okay? But no matter what, if you can treat the underlying cause, I know this can sometimes be daunting looking at all this stuff, that may help the issue. But the big thing that you want to be doing is supporting their airway and helping them to be able to get oxygenated and clear off that CO2. And so what you may have to do for them is, we kind of talked about it a little bit, is empirically, you may have to provide a non-invasive positive pressure ventilation mechanism. And so this can be things like high flow nasal cannula, or it could be things like BiPAP, okay, where you actually provide some respiratory support for them. Or the second thing is that you actually invasively mechanically ventilate them. And you do this in a way where you help to increase their respiratory rate and increase their actual depth to blow off more of that CO2, okay? So these are the things that you want to be thinking about in a patient who has a respiratory acidosis issue. All right, Ninja Nerds, in this video today, we talk about respiratory acidosis. I hope it made sense. I hope that you guys did enjoy it. And as always, Ninja Nerds, until next time.